Good morning, everyone. We are very happy to welcome you in Nice for this very first Nice Shoulder e-course for nurses and PA. We're going to talk right now about the gross anatomy of the shoulder because everybody knows that it's totally different between the OR and the anatomic lab. So it was interesting to compare those things. In the OR, the landmarks are on the skin and also with mini-invasive surgery with arthroscopic view like here. So it's difficult to understand sometimes. So it's a good thing to come back in the anatomic lab and to see different muscle, different insertion, different nerves and vessels. That's why we're going to talk about the bone of the shoulder and then the joints of the shoulder. And then we'll go on with the muscles, the cuff muscles, and we'll finish with the vessels and nerves. Let's begin with the bone. The bone, including the shoulder, is made about the clavicle, the scapula, and the humerus. And you have to see this kind of bone on the X-ray, on pre-op surgery, pre-op planification, for example. We can see here the humerus on the frontal view and the scapular and the clavicle right there. And we can see here a nailing for a fracture of the upper part of the humerus. You can see here a reverse shoulder total arthroplasty, and right here a fracture of the upper part of the humerus with 3 fragments. It's not the topic of this talk, but it's interesting to analyze and to identify different structure on X-ray. We can see also on the lateral view that the shoulder is not in the profile exactly of the body, but behind the thoracic cage. You can see here the scapula, and you can see easily that the scapula is behind the thoracic cage. So if you need a good profile lateral view X-ray, you need 20 to 30 degrees of reorientation of X-ray. It's interesting to understand also that the range of motion between the scapula and the thorax is a kind of joint, but it's not a joint. It's a possibility for the scapula to slide on the ribs. That's very interesting to see here that the only bone which make link between the upper limb and the trunk is the clavicle. That's why when you have a fracture of the clavicle, it's very painful and very difficult to move the upper limb. That leads to a big disability. Let's see the scapula. We have, different area. This is the joint, the cartilage area. You have the spina of the scapula and the supraspinatus fossa, infraspinatus fossa, the acromion, and the coracoid process. On the humerus, you can see here the major tuberosity and the minor tuberosity and the gate between for the biceps. Let's see now the joint of the shoulder. There is 5 really joints for the movement of the shoulder, but we're going to focus on the scapulohumeral joints. You can see here the shape of the scapular surface, which is very flat. That's why the labrum is made for. It's to improve the shape for the humerus head. You can see here the ligament between the acromion and the coracoid process, and here the ligaments and between the coracoid process and the clavicula, which are important in the stability of the shoulder and which can be torn in traumatology. You can see here humeral prosthesis, so it's the replacement of the humeral part only. And here you have an example of surgery for stabilization of dislocation of the scapulohumeral process. You have an example here of anterior dislocation. The humeral head get out of the joint in the anterior part. We're going to see now the capsule and the importance in the stability of the shoulder. You can see here the lateral view of the scapulohumeral joint, and you can see the capsule right here, which is very thin at the posterior part or the anterior part. This is the joint capsule exactly. It's easy to see when you have a rotation movement that you need some space in the capsule, and if you have not enough capsule, you would have stiffness, of course. And here are the tendon of the rotator cuff muscles. Now we're going to go to the rotator cuff. We're going to begin with the subscapularis muscle. Is placed in the subscapularis fossa in the anterior part of the scapula, and the muscle has a proximal insertion like this and distal insertion on the lower tuberosity of the superior part of the humerus. And you can see right here that if you make contraction of subscapularis, you will have internal rotation. Let's see the supraspinatus muscle. The position of the proximal insertion is in the supraspinatus fossa, just above the spina of the scapula. And the distal insertion in blue here is on the upper part of the major tuberosity of the humerus. So if you understand the position of the muscle, you understand the function, because the muscle has a direction on the frontal plane. That means when you make a contraction of the supraspinatus muscle, that will lead to an abduction movement, as you can see here. Now let's talk about the infraspinatus and teres minor muscle, which can be described together because they have nearly the same insertion proximally and distally, so they will have the same function. First, the position. They are in the infraspinatus fossa. The proximal insertion is in red and the distal insertion is in blue in the posterior part of the major tuberosity, and we are on the posterior part of the joint. That means if you have a contraction, you will have external rotation. So you can see right here the difference between the internal rotation muscles and external rotation muscles. It's a question of insertion. What else? We have 4 described muscle, including the rotator cuff, but we have also the biceps and the triceps, which are included in the mobility of the shoulder. You can see here the long portion of the biceps in the front, and you can see the long portion of the triceps in the back of the shoulder. And right here, the long portion of the biceps brachialis. This is the position of the long portion of the biceps that could lead to pain. So of course, that's where the tenodesis will happen when you have pain. We're going to finish with the teres major muscle, which has a different insertion distally. The proximal insertion is on the posterior part of the scapula, but the distal insertion is on the anterior part of the humerus. So when you make a contraction, you will have an internal rotation of the shoulder. That's why it's important to know the anatomy of different rotator cuff muscles, the 4 we have described, and also the biceps, because in surgery you will talk about rotator cuff tear, like here you have a torn of the cuff. Right here you can see the liquid in white, and so you have to understand where does that mean if you look to the anatomic specimen, because you have to link what you see on the images, what you know on the anatomic specimen, and what you see during the surgery in arthroscopic surgery. The shoulder has movement also with other kind of muscles. We can see them very quickly. We have already seen supraspinatus, infraspinatus, and teres minor. We can see now teres major. We have seen this. This is the coracobrachialis muscle. This is the serratus anterior muscle, which is very important for the scapula. And this is the levator scapula muscle, the little and the big rhomboid muscle, and the trapezius muscle, which are very important. We can see also here the little pectoralis and the subscapularis muscle, the homoyoidean muscle, and the great pectoralis muscle, very important for internal rotation, as latissimus dorsi and deltoid muscle right here. Let's talk for the last part of this talk concerning the vessel and nerves, because most of the time you don't see them. You don't have to see them. If you see them, it's not a good option, so you have to know them to avoid them. Let's begin with the veins. The superficial vein we can see is the cephalic vein between the deltoid muscle and the great pectoralis muscle. This is the way where the surgeon can make a deltopectoral approach. And you can see right here that the superficial vein go in the deep vein, subscapularis, subclavicular vein, just over the little pectoralis muscle. Let's see how it works. You can see the cephalic vein and the subclavicular vein below. So you can see the the veins which goes to the juguloclavicular system just in front of scalene muscle. Let's see the arteries. In the beginning of the shoulder, you can have the three arteries, the subclavian artery, axillar artery, and brachial artery, just behind the insertion of the little pectoralis muscle. At the end, nerves, of course, you don't have to see them, but sometimes you have to know where they are. The nerves are around the axillar artery. So if you put away the little pectoral muscle, you can see all the branch of the brachial plexus. They are posterior to the scalene muscle. They are posterior to the axillar artery. And we have then the terminal branch of the brachialis plexus, which leads to the terminal branch, from the trunks to the terminal branch, for innervation of the upper limb. That's why for me it's very important to learn anatomy, to be able to go with minimally invasive surgery, with arthroscopic surgery. You have to know where to go and where not to go. Thank you for your attention.